Ravi. Thanks to you all for joining. And as Ravi's mentioned, the focus of today's webinar is looking at intervention 3, the delayed intervention, or the GM-CSF intervention in SepTiC. So we'll talk a little bit about the background, the eligibility criteria, the nature of the intervention, and then I'll hand back over to Ravi to cover some more general study updates today. I think one of the things that we probably need to focus on is what GM-CSF does, and also the side effects to the drugs, and that's probably the thing that people are most interested in. We recognise that people will not be familiar with the administration of GM-CSF, although they may have experience with the administration of G-CSF in their clinical practice. And as it's a novel intervention, there is a little bit of apprehension about take-up of the study. Can I have the next slide, please, Ravi? So you'll be familiar with the early interventions. So we have the kind of rapid diagnostic intervention, the conservative fluid intervention, and the one on which we're going to focus today is GM-CSF. So the question that we are trying to answer within SepTiC is, does GM-CSF compared to placebo improve outcomes in a high-risk subset of patients with sepsis? And the premise or the background from this is that in patients who are admitted to critical care, approximately half of those patients will show evidence of acquired immune deficiency, which puts them at risk of a poor outcome due to complications such as hospital-acquired infection. And we hope to restore people's immune function such that they are better able to recover from critical illness. And obviously, there's a kind of overarching question that covers all three interventions as to what the relative cost effectiveness of each of these interventions are compared to standard care. So if we look at what GM-CSF is, this is a naturally occurring product that our body produces. It is a substance which fosters the development and maturation of cells from the granulocyte and myeloid lineage. It can be produced by cells that are found in the blood, but also cells that aren't found in the blood. And as I say, leads to maturation of different forms of white cells in our blood. So principally cells of the innate immune system, although as a result of its effect on the cells of the innate immune system, it also has an effect on cells such as lymphocytes. Can I have the next slide, please, Ravi? So I think this is the kind of thing that probably most people are interested in. So what happens when they administer GM-CSF, and I guess would be the source of apprehension. In deciding what dose to administer within the trial, we considered side effects and the complications of administration. So complications or side effects of administration are more likely to happen when a large dose is administered, so in excess of 10 mics per kilo per day. The dose that we have chosen within the trial sits around 5 to 10 mics, so less than that kind of threshold of 10 mics per kilo per day. There are certain patient groups that are more likely to have complications, and they feed into our exclusion criteria. So patients who have a solid organ or bone marrow transplant, patients who have leukemias that are requiring active treatment are examples of patient groups that we've excluded on the grounds of safety and trying to reduce the risks of administration. In terms of the route of administration, we've chosen a subcutaneous administration route, and there is less likely to be complications associated with the subcutaneous administration in comparison to an intravenous infusion or bolus dose. And in terms of the reactions that happen on administration of GM-CSF, there are commonly occurring minor side effects such as fever, myalgia and malaise, so almost flu-like symptoms, and a local skin reaction. And there are more serious reactions that occur in less than sort of 1% of patients. So there is something described as a first dose reaction in which patients may become hypoxic or hypotensive. There is the risk of thrombosis that occurs by the increase in cell count and viscosity of the blood. And there is a theoretical risk of pericarditis and also a risk of transaminitis, so liver dysfunction measured by safety bloods such as the ALT and other elements of liver function tests that we measure as part of our safety bloods. Can I have the next slide, please? So how does the GM-CSF intervention fit into the trial? As I say, it's the kind of delayed intervention. So patients will be randomized to interventions 1 and 2 within the first 24 hours of admission to critical care, whereas patients will only be recruited to the GM-CSF intervention once we've seen evidence that there are a level 3 patient, so they either require invasive mechanical ventilation or multi-organ support in the form of renal replacement therapy and vasoactive support, and they have evidence of a persistent lymphopenia. Next slide, please. So this part of the trial can stand alone. So patients aren't required to be recruited to interventions 1 and 2 in order to be eligible for the GM-CSF intervention. As I've mentioned, they are a level 3 or requiring level 3 support. So that already means that they are a sicker population than all of the patients that are eligible for interventions 1 and 2, and they will have persistent lymphopenia based on the white cell count that you measure. And in order for it to qualify as persistent lymphopenia, that requires 2 blood tests taken at least 12 hours apart. Can I have the next slide, please, Robbie? So in terms of our inclusion criteria, the patients are either intubated and mechanically ventilated and expected to continue to be so for another 24 hours or on 2 organ support, so vasopressors and renal replacement therapy. And the threshold that we look for in terms of the lymphocyte count is having an absolute lymphocyte count of less than 1.2 times 10 to the 9 per litre on 2 consecutive calendar days, at least 12 hours apart. And in terms of our exclusion criteria, we have some additional exclusion criteria. So patients need to be randomized and consented within the first 5 days of their ICU admission. They should not already be receiving G-CSF or GM-CSF for another clinical indication. If they have a total white blood cell count of greater than 50 times 10 to the 9 per litre, they aren't eligible for the study. If they have an allergy or adverse reaction to GM-CSF or any yeast-derived recombinant product, they're not eligible. If patients are pregnant or breastfeeding, then they're not eligible. And if they've got an active hematological malignancy, which we define as being treated within the last 5 years, they're not eligible. And if patients have a solid organ or bone marrow transplant requiring immunosuppression, they're not eligible. And if patients have a weight in excess of 125 kilos, they're not eligible. So those are the additional exclusion criteria in addition to the core exclusion criteria for the remainder of the other interventions. So our intervention is GM-CSF versus matching placebo. So in terms of administration, the people who would be administering IMP will be blinded. For those patients who fit into the weight category of 50 to 125 kilos, they will be administered 500 micrograms, which is 2 vials of GM-CSF once a day for 8 days. And if they are less than 50 kilos, they will receive 1 vial subcutaneously once a day for 8 days. It's prepared as a lyophilized powder, which is kept refrigerated and reconstituted with 1 ml of water for injection or bacteriostatic water. And as I say, the duration of treatment is 8 days. It is intended that we administer GM-CSF for patients who've been discharged from critical care and onto the ward. But if that is logistically not possible, it won't be classed as a protocol violation. And the agent needs to be stored, as I say, between 2 and 8 degrees. Next slide, please. So in terms of IMP delivery and what sites will be expected to receive, they'll initially receive 8 boxes, 4 with active IMP and 4 with placebo. Each box will contain 16 vials, which is equal to enough IMP for 1 patient worth of of GM-CSF. Each vial contains 250 micrograms of IMP or placebo, and so the kind of presentation of the GM-CSF will be in a paper box as illustrated with a foam inset and labels on the vial and the box as illustrated. So in terms of the visit schedule, this kind of covers all aspects of the trial. So screening will happen for the early interventions from day 0 prior to randomization. Informed consent for interventions 1 and 2 will be sought within 24 hours. But for randomization to the GM-CSF intervention, that can happen anytime up to 5 days within 120 hours of the ICU admission, provided the eligibility criteria, i.e. in terms of organ support and persistent lymphopenia, are fulfilled, and there are no exclusion criteria. There are some additional research blood samples to be taken for the GM-CSF trial, which Ravi will cover shortly.
Okay. So we're just going to go over a brief few slides about IMP management and when you get your IMP delivery at the start of the study. So these, for any sites that have joined that are in the setup process, we do cover this during the SIV. These are taken from the SIV, and we also have our IMP handling manual and our IMP management plan, which are the more has the whole process in detail. But just to go over it briefly, the trial teams, this is the SepTiC trial management team. We complete and submit all IMP orders to our distributor, which is Victoria Pharmaceuticals. And in your first shipment of IMP, your site will receive 8 kits, which will include equal amounts of IMP and placebo. This will be delivered to the trials pharmacy. They'll take the delivery and note the kits on the pharmacy accountability log and confirm the kit delivery with our database team. Prior to opening, we'll make sure that the unblinded pharmacist has access to the system we're using, which is sealed envelope, and they'll have unblinded access to the system. The kits will then be stored in the pharmacy fridge until they're ready to be dispensed. So our database team will activate 2 IMP and 2 placebo kits on the database, and these will need to be dispensed to the ICU. The unblinded pharmacist will be able to see via sealed envelope the 2 kits, the 2 IMP and 2 placebo, which are activated. The rest of the team, of course, the SepTiC trial team and the site team will all be blinded to this allocation. The unblinded pharmacist will then be able to dispense those 4 activated kits and update the accountability log. And all the log templates are also available on our website. The 4 remaining kits can then be stored in the pharmacy fridge. And then once the ICU team receive the IMP, they will also need to store it in the fridge until randomization and update their ICU accountability log. In terms of restocking, when the ICU has 2 kits remaining, they should request further stock from the pharmacy. The unblinded pharmacist will be able to follow the same dispensing process again, and they'll be able to make sure that equal kits are provided to the ICU team and update their log. When there are just 2 kits remaining in pharmacy, a new order should be placed with us, the sponsor trial team, and the whole process will begin again. In terms of returns and destruction, for any dispense files that are unused or empty, they can be destroyed at site without sponsor approval. However, sponsor approval will be required for any damaged files or in the event of IMP recall or expiry of the IMP. And for these last 2 points, the IMP destruction log should be completed. So I'll just pass over to my colleague Paulina to just give a bit more information about sealed envelope and the unblinded pharmacist.
Yes, so the unblinded pharmacist, each site will have at least one unblinded pharmacist. And I think from the sites that we currently have open, I think most of the sites have at least two unblinded pharmacists. So the unblinded pharmacist will have to complete the sealed envelope training log, which you will complete after you've read the sealed envelope training slides. And then they will fill in a user activation form. And that's all part of the setup. So once you send that to us, we will then be able to grant you sealed envelope access. When the IMP has been delivered, you will then email the database team, as Ravi mentioned previously, and we have a template for this email just on our website as well. You will then email the database team with what kits have been delivered. The database team will be able to then activate the 2 IMP and 2 placebo, and you will then be able to send that up onto the ICU.
Thanks, Paulina.
And then sample collection. If you are participating in the first two interventions, you will take your baseline samples, and if the patient is also randomized to GM-CSF, you will also take an extra PAX gene sample on day 1. So that's on top of the PAX gene sample that's already being taken at baseline. So what we will do is we'll send you a separate plastic bag with about 9 or 12 PAX gene tubes in that. So what you will have to do is just grab that extra PAX gene tube and put that into the sample safe box that you will be sending to us. That's if the patient is randomized on day 1, the same as the diagnostic intervention. However, obviously, because of the 5-day inclusion time, if the patient is randomized on day 5, you will just start the day 1, day 3, day 5 on that day, and just use like normal the safe boxes.
So I will just pass back to Dr. Rostron to go through some FAQs that we have been receiving for the GM-CSF arm. And if you do have any other questions for Dr. Rostron, please do ask or put in the chat that we have.
So this is a common question as to why we're using absolute lymphocyte count as a way in which to enrich the population randomized to the GM-CSF intervention. A persistent low lymphocyte count identifies an immunosuppressed phenotype, which is associated with a higher risk of mortality. It isn't the best characterized example of a sepsis-associated immune cell biomarker, but probably the best characterized is monocyte HLA-DR, which is not available for routine clinical testing within the NHS, so it's not accessible for a trial of this scale. Persistent lymphopenia has been shown to be correlated with measures such as monocyte HLA-DR, and it is routinely measured as part of the white cell count differential within the NHS. So the rationale for its use is because it's an accessible biomarker to identify an immune suppressed phenotype, which further enriches the study population in addition to the requirement for level 3 support on critical care. Next slide, please. So because GM-CSF stimulates granulocyte populations, people ask whether or not they need to monitor their neutrophil increase. It's not required for neutrophils to be monitored, but if the total white cell count exceeds 50 times 10 to the 9 per litre, then GM-CSF should be stopped and a protocol deviation form should be completed. So you'll remember from the initial eligibility criteria that a total white count of 50 times 10 to the 9 per litre was an exclusion criteria, and should a patient's white cell count rise to above this threshold, then the IMP should be stopped. And this covers what to do if a a dose of IMP is missed, so we intend for the IMP to be administered every day for 8 days. If a dose is missed for any reason, this ought to be capped in the daily data form on the ECRF, and a reason why should also be documented. If the patient's discharged from the ICU before the 8th day, then the study drug should be given on the ward until 8 doses in total have been given, if logistics allow, and we acknowledge that that's not always possible in every centre. But it won't be a protocol deviation if this isn't possible. So our intention is to complete an 8-day course, but if a patient's been discharged from critical care, then it's not absolutely essential that IMP is administered following discharge. However, if the patient is discharged from hospital before the 8th day, then the study drug ought to be stopped. Next slide, please, Robbie. And I'll hand back to yourselves.
Yeah. Thank you. Just before I go on to a couple of study updates, I just wanted to pause and check if anybody had any other questions about the GM-CSF intervention. Yeah, Sally?
Hi there. I was just wondering, as the IMP needs to be given over 8 days, is there a requirement for the person administering it to be GCP trained, or is it all right for the clinical staff to give it?
So we do have a specific training for IMP administered. So the answer is no. If it's part of their regular duties, they wouldn't need to be GCP trained. We just have a shortened training that they would need to complete and a training log for them to sign.
Okay, brilliant. Thank you, Ravi.
Any other questions about the GM-CSF intervention or eligibility? Yeah. Someone's got their hand up.
Sorry, can you hear me?
Yeah.
Yeah, apologies if you already covered this, but if the pharmacy dispense 2 boxes to stay in the fridge that's in our little research office, how do we know which one to take? Will there be will it be coded and we're told which one to take, or?
Yeah, so I'll just cover it actually in the next bit about randomization. But when you randomize a patient to the GM-CSF arm, that allocation is given to you on the screen. So it'll give you the kit code, and because of all the processes before about allocating the kits on sealed envelope, on the system it'll know which kits are at your site and which ones have been activated, and it'll give you one of those kit codes.
Okay, lovely, thank you.
Yeah. Okay. Any other questions?
Hello, this is Kim from Bristol. Hello. You just mentioned about administration of the IMP, about having the nurses having training and going on the log. I thought as part of their clinical role of administrating medication, they wouldn't need that. We've got quite a big ITU, and I'm just trying to work the logistics out of getting all of our nurses on that paperwork, or would I just go with the paperwork with the nurse that's looking after the patient that day?
Yeah, so I can send you on email the training log and the slides. So just for IMP administration, it's a set of slides. I don't think they're very long, probably less than 10 slides. And then there's a training log which multiple people can be added to. So instead of having lots of bits of paper, you could probably just keep adding more staff who might be looking after that patient and administering the IMP.
Okay.
I can send all this to you on email if that's helpful.
That would be lovely. Yes, please.
Yeah.
Thank you.
Okay, no worries, Kim. Okay.
Sorry, Ravi, just thinking along the same line. If the staff have done their mandatory training for IVs and stuff, is that not adequate training?
Unfortunately, it's a sponsor requirement that we will have to demonstrate some training on our IMP. just to
Okay.
show that they have some awareness of what the trial is and what the IMP is, but we've tried to make it as short as possible.
Yeah.
Question from Ashraf. No, we can't hear you. But if you put your question in the chat, we might be able to follow up, or we can follow up on email as well. Okay. And was there another question? What I'll do is we'll go through some of the study updates now, and then if there are any other questions about GM-CSF intervention, then we can just go through it at the end. So recently, a few of our users have experienced a few issues with randomizing on Open Clinical, so we thought it would be best to maybe just kind of go over a couple of details just to help prevent users from getting stuck with getting the randomization allocation. And we've tried to make some videos, so hopefully it's a bit more clearer on what to do. So here I'm just randomizing a patient to the GM-CSF arm and completed all the screening forms. I'm just completing the randomization confirmation. All the other information on the form has come through correctly, and these are all the read-only fields. So all I would be doing is confirming that I'm happy to randomize, entering the date of randomization, and confirming the patient is eligible, and marking the form as complete as all the data has been entered. And what we advise is just to wait a few moments before opening the randomization assignment form. So I'm not clicking on anything here, just kind of waiting. And then you can see that the form has changed and the system has updated the form, and it's turned from blank to orange. So now we know the allocation has been populated, and then you can go into the form. And here you can see the treatment allocation. So for GM-CSF, it's the kit code. You'll then need to go to wherever the kits are stored on your ICU and use that kit for this patient. And now you can mark the form as complete. And this next video will just show you what happens if we don't wait. So again, we'll just go through the same steps. Randomizing the patient, entering the date of randomization. And then in this example, I'm just going straight into the assignment form. And unfortunately, because the system hasn't had time to get the information, the treatment allocation is now blank. So what we advise here, if this has happened, is to just close the form, but don't complete it, because the data is not available. And you can see now the system has had a chance to update it. We can now view it on the edit mode. And now the kit code has been populated. And we can now mark the form as complete. So just to summarize, when randomizing, this is to any intervention, not just GM-CSF, but when you've completed the randomization confirmation, just wait. And you can see that we didn't have to wait long. It was just a couple of seconds for the system to show that the assignment form has updated. Once you can see that, then open the form and view the assignment. So in the second video, the assignment was blank. Then in this example, you should close the form, but don't click complete, and wait a moment before reopening in edit mode. we've been in touch with Open Clinica, and they informed us that if this doesn't work, we should not keep trying that route again, because the database can kind of get stuck, and we can accidentally kind of lock the form. So we may, in that example, need to clear both forms and try randomizing again. But I would suggest calling a member of the SepTiC trial team, and we can talk this through with you on the phone. So our guidance does already suggest to wait before opening the randomization assignment form, but we are also in the process of updating it just to include even more detailed information on how to help you if you get stuck. I'll just pass back to Paulina for this last slide, just for an update about the lab.
So as you all probably know, because I've sent out quite a few emails about this, our lab has now moved from, it's still called Medical Diagnostic Unit, but it's now moved from the St. Mary's campus to Chelsea and Westminster. So I've emailed all open sites with this update, and I've also posted new shipping labels. So we now have 24-hour tracked shipping labels. So we're still using the same safe boxes as we have been using previously. So if you just take one of these labels and pop that onto the safe box, and make sure to note the tracking ID and send that over to us. So then both yourself and us can track the samples, and none of them get lost, and we know when they're coming, so we can get the results to you as quickly as possible.
So that's all of the study updates. This is just a reminder of all the ways to contact us. All study-related emails or queries should be sent to our SepTiC inbox. We also have our SepTiC website. There's a site staff page which has all of our approved documents, templates, videos. So we have videos for sample collection, randomization, all of our webinars we record and upload there. We also are on Twitter, and we post any study updates on there. So new sites that we've opened and any recruitment milestones that we've hit. And also you can see all of our videos on our YouTube channel as well.